So the rationale between why should we approach the epicardium of the heart is that initially when ablation was described as a surgical technique, people were already utilizing the epicardium. So, but when endocardial ablation was done, it was the endocardium that was touched and the epicardium that was difficult to touch. And a lot of scarred myocardium, as you can see in this picture, the scar doesn't limit itself to the endocardium. You have scar in the endocardium, you have scar in the mid-myocardium, and you have scar in the epicardium. So it becomes sometimes important to reach this separate sections of the scar in the epicardium, where the endocardium itself is not responsible for the critical parts of the circuit. So important questions regarding epicardial access and ablation is, the first important question is, when to perform an epicardial ablation, when do you require access for an epicardial ablation, the relevant anatomy regarding a successful epicardial access, mapping of the epicardium, and most importantly, how do you avoid collateral damage and complications when doing this access. So a 53-year-old male, HCM with an end stage or burnt out HCM with LV dysfunction. So a wide fractionated QRS, wide QRS complexes, and I'm sorry. So it's a wide QRS complexes. So this man had a ventricular tachycardia. So what do we immediately see with the ECG with regards to the ventricular tachycardia? Sometimes these patients when you have a lot of structural heart disease, sometimes it's very difficult to understand where the QRS is starting and where the QRS is ending. So if you see that the red line is the starting of the QRS, you can see that the initial delay from the start of the QRS till the peak of the QRS is very slow. So oftentimes when you have a slurred QRS where it takes a long time to sort of reach the peak, it is suggestive of an epicardial origin. But we need to be careful because many of the rules and the numbers that have been derived for epicardial versus endocardial VT have all been derived from patients with normal hearts or structurally normal hearts. So you need to have a clinical idea when using these numbers. So this was a patient who had a predominant epicardial scar, a HCM patient. So these ECG criteria, a pseudo delta, intrinsicoid deflection time, they all mean sort of the same thing. Does it take a long time from the start of the QRS to reach the peak of the QRS? And if it takes a long time, usually it is suggestive of an epicardial origin for the VT or epicardial exit for the VT. So there's a few things that now we don't just have the ECG, we have good echocardiograms, we have a good cardiac MRI. So you will have a very good clue where the scar is in these patients before you take them up for ablation. So in these patients, if you suspect there's an epicardial exit for the VT, these are the patients that you need to access the epicardium. Now accessing the epicardium, a pericardiocentesis is a routine procedure that we all do. And the reason it's easier is there's a lot of fluid between the two parietal layers of the pericardium, so it makes it easier to access the space. But in a patient with a normal epicardium where there's only 15 to 20 ml of fluid, the anatomy and the collateral damage is very important. So this is Larry's space that you're seeing on the right in the blue. You have the sternum anteriorly, you have the pericardium posteriorly, and you have the dome of the diaphragm inferiorly. So the small gap between the dome of the diaphragm is what we are trying to enter. Now that is what you're seeing as the space of Larry, and I'll just show you a few slides regarding the anatomy. So when you try to access the epicardium, usually we use a 2He needle, and sometimes it's slightly difficult to get access to these needles now, but it's a 150 millimeter, usually 18 gauge 2He needle that we use. And the idea here is you need to enter slightly leftward of the tip of the xiphoid process, and that is what you're seeing in the right side picture here. So what are the anatomical structures at this site, and why is it sometimes difficult to get access in patients? So anatomical variations are many, and I just want to show you a few things. So this is, if you can imagine that you've cut you're looking at the heart from the right now. So the liver, the diaphragm, the pericardial space, and the sternum. Now there are two ways to approach the epicardial space. One is an inferior access. And an inferior access is sometimes slightly easier because sometimes there is a bigger space inferiorly to access this space. The problem here is your structures here that you could potentially injure are your subdiaphragmatic vessels, your diaphragm and your liver. The other way to access your epicardial space is your anterior axis. So you can see the difference in both of these arrows. One is more caudal, one is more cranial, one is slightly more angulated when you take the axis, one is less angulated. So this is two ways that you can approach. Both have their pluses and minuses, but it depends on where the predominant anatomy that you want to map and ablate. So I'll just try to play this. Excuse me. Is there a clicker? Sorry, one second. Oh. Can you just play the video? Just, can you scroll? Yeah. So this is how you're entering the epicardial space. So initially the best thing is to do it is to use it with a little bit of dye. So as soon as you enter the epicardial space here, what you just saw is you will feel some pulsations. And it's always important to use your Tuhi needle is a slightly up-facing needle. You want to keep your needle tip away from the RV surface. So if you're going anteriorly, you want the Tuhi needle to face towards you and inferiorly away from you. And as soon as you feel the pulsation, 1 or 2 mm from there, you will enter the pericardium. And once you enter the pericardium, use your normal soft tip J-tip wire, go to an LAO projection and sort of loop it around the heart, and this is like a normal pericardiocentesis. Now the important thing here is when you use this kind of contrast guided epicardial approach, you need to be sensitive of two things. That sometimes you will be staining the diaphragm. So you will be thinking that you're entering the epicardial space. If you see consistent staining and that sort of not washing away, it's either one of two things. It can be the diaphragmatic surface that you're sort of penetrating, or you may be in the RV. So some people are comfortable in LAO projection. Some people go all the way completely lateral when they take the epicardial puncture. Most of these patients, the other advantage that you have is most of them will have an ICD lead. So you sort of already know where the RV is in these patients. If you have a CS decapolar catheter and already an RV defibrillated lead, you can sort of estimate where the RV anatomy is as well. The second part is, as soon as you take the axis and you put a sheath in, never leave just the sheath in the epicardial axis, because that sheath has a pointed edge, and that itself may injure the RV wall. So as soon as you get an epicardial axis, even if you have other things to do, make sure you get a catheter or a catheter into the epicardial space, just to make sure that you don't have the sharp surface of your sheath pointing towards the RV. So, and this is all far more easier in a patient with a normal pericardium and who hasn't undergone a previous cardiac surgery. I think other people will also agree that this becomes almost, it becomes a no-go in patients who have already had a prior cardiac surgery and patients who have adhesions. Everyone has their slightly different method of how they do systemic anticoagulation. Preferably, it is to take your axis before you systemically anticoagulate the patients. If you've already done an endocardial ablation, you're not happy, patients on full heparin, you can reverse the heparin and then take the epicardial axis. Using LAO or left lateral is up to the operator, and never leave your epicardial introducer exposed. Always keep at least a dummy catheter inside. So sometimes you can map the epicardium, and I'm not going to go fully into the mapping techniques, but one slightly different thing that is there in the epicardium compared to the endocardium is it is slightly easier to move around the epicardium because it is a freer space compared to the endocardium. Your mapping itself, the one structure that is sort of limiting your mapping capabilities is some patients can have a tremendous amount of how to say it? Your scar in the epicardium is not always as consistent in the scar in the endocardium. So you will have, depending on like the initial patient I showed you with hypertrophic cardiomyopathy, scar may be slightly in unexpected areas, and I'll show you what I mean. So This is just showing late potentials that are recorded in the epicardium, and this is the mapping techniques per se are similar to the endocardium. Now, the other thing that I want to talk to you about is the collateral damage. So, what are the different kind of structures that can be injured when you take an epicardial access? We often talk, even in the safest of hands, probably around 5% of complications occur. Why is that? We often think that the RV is the only structure that is injured during an epicardial access. This is not such. There is injury to the liver, subdiaphragmatic vessels. So as soon as you see blood through the epicardial stick, it's not always because of an RV puncture. Even injury to the vessels below the diaphragm will cause this. We have had a few patients like this one where your epicardial stick is very close to your colon. Why is this? Because you have a very large dilated transverse colon. So in these kind of patients, we have had to actually put in a flatus tube, reduce the size of the colon before taking the epicardial puncture. So this is just to show that these are the structures that are often, and the one artery that we often don't disregard is you have a superior epigastric artery that you're seeing in the second picture here. The pointer is not working. The superior epigastric artery runs laterally. So it's not often a problem. So when you try to take your puncture on the lateral side of your rib away from your xiphoid process, oftentimes the superior epigastric artery can be injured. So that is also something to keep in mind, although it doesn't happen very commonly. The other very important thing is an inspiratory breath hold. This is sometimes, most of these patients who get this ablations are already, they may be under general anesthesia, and you can utilize this by doing a deep inspiratory breath hold. So what happens when you do a deep inspiratory breath hold is, you push the diaphragm down, and by pushing the diaphragm down, that potential space for access between the heart and the diaphragm is more. So it's slightly easier to take access into the epicardial space when you take a deep inspiratory breath hold. So what we tried to simulate what would be the best route for access in each of these patients by doing a pre-procedural CT that defined at what angle and site we were supposed to enter the epicardial space. And we sort of, I'll show you in the next slide. We loaded the epicardial, this is the 18 gauge 2He needle, and we loaded it onto a protractor, and based on the angle that was determined in the CT, we sort of entered the epicardial space at the same angle. The advantage here is you know at what angle you're supposed to puncture, and you know at what depth you're supposed to enter. So for example, if it is 5 centimeters that you're entering, you'll have an idea about where you're going to enter, and it makes it slightly safer and easier procedure. The phrenic nerve is a problem and this is what I meant. The phrenic nerve is something that you encounter as a epicardial structure. And sometimes what happens is you will have a phrenic nerve damage when ablating in the epicardium. So in some instances, we have had to inflate a balloon to sort of separate the phrenic nerve away from our ablation catheter to perform the ablation. We prefer that before an ablation is done at each site, that you shoot the coronaries. We would like at least 3 to 4 mm distance from the coronary arteries in at least 2 views, and this is something that's very important. I think I have 2 slides, I'll just finish. There's been a lot of work done on how to avoid post-procedure pericarditis. It has now become our center's procedure that we inject Kinocort after the procedure just to help with the post-pericardial inflammation. Every center has their own way that they do it, and most centers they give some oral NSAIDs as well. So an epicardial approach can be a useful adjunct to catheter ablation of VT. It's helpful in both ischemic and non-ischemic patients. We need to be careful on how we access the epicardial space because you can have complications in 5 to 10% of patients. So you need to look attention to the details and especially post-procedure as well. So thank you.